I'm Dr. Meghan Davis, and I lead the Hamilton Family Health Team Green Initiative, which strives to help primary care reduce our carbon footprint. And I'm joined by Dr. Dee Mangin, all the way from Christchurch, New Zealand. She is a recognized worldwide primary care expert on this topic with positions at both McMaster University and at the University of Otago. An especially warm welcome to our Kiwi colleagues on this call. New Zealand has a very special place in my life and in my heart, as my eldest daughter lives in Wellington. In fact, this collaboration was born via a recent trip there where I met the lovely team at the Royal New Zealand College of General Practitioners. I also want to acknowledge the creativity, research, design, leadership, and organizational skills of our project manager, Tatiana Gajowski, who will be giving our land acknowledgement.
So welcome everybody, and just quickly before we begin, we'd like to acknowledge that we are presenting on the traditional territories of the Mississauga and the Haudenosaunee nations, and within the lands protected by the Dish with One Spoon Wampum.
So here's our disclosures. No pharmaceutical support. However, we have received support from some not-for-profit healthcare institutions, and I'm entirely grateful to my organization that hosts and support this work, the Hamilton Family Health Team. Okay, so this webinar is part of a series. Today we are presenting Module 9, Prescribe for Impact. Recordings of prior modules on puffers, on plants, and on prevention are all on our website. So within the project, we made a conscious decision to research and support environmental initiatives that have a co-benefit for the health of our patients. We call this high-quality, low-carbon care. Within our agenda, I'll first quickly present the logic model for why prescribing for impact is good for our patients and our planet. And then Dee will take us through some terminology with 5 specific drug classes. We'll explore barriers and strategies, and then we'll end with a quiz. And then we'll stay on if you would like for the Q&A. Okay, let's start with how, by ensuring we prescribe for impact, we are providing high quality care. So the studies reflect that there's an opportunity to improve patient well-being when we prescribe carefully and we deprescribe appropriately, with fewer side effects, drug interactions, lower cost, fewer hospitalizations, higher quality of life, including less identification. And patients are receptive to this, as we can see from a recent study of over 200 patients in New Zealand that found that 1 in 2 patients reported feeling that they were taking too many medications, 1 in 5 considered their medications burdensome, almost 3 out of 4 wanted to be involved in the decision-making about their medications, and 4 in 5 were willing to stop 1 or more of their medications if their prescriber thought it was possible. In this bar chart, we can see that our prescribing rate for 4 common classes of medications is higher than the worldwide rates. So, and studies done, for example, in the UK identified that there are many low-value medications being prescribed, up to 5.8 million in 2018. So I think it makes sense for all of us that unnecessary medications can harm the patients we care about, and they can also harm the planet that we care about. This is a tree from Ontario's Environmental Action Partnership called PEACH. It shows the impact of various healthcare interventions and the greenhouse gas emission savings opportunities. And deprescribing is depicted as such a low-hanging fruit that it's actually on the ground. Not only is there the co-benefit of improved patient health that we just talked about, there's an additional co-benefit of reduced spending, as pharmaceuticals represents 14% of Canada's healthcare expenditures. Every healthcare activity that's on that tree all has a footprint. Every test that we order, every treatment we provide consumes energy and materials and generates waste. Healthcare is a significant greenhouse gas source, about 5% in Canada, and almost 4% in New Zealand. So it's important for us to prioritize our environmental efforts. Which do you think is a larger source of greenhouse gas emissions in healthcare in Canada, pharmaceuticals or hospitals? So it's close, but it's pharmaceuticals, with a full 1/4 of Canada's healthcare system's greenhouse gas pie. Surprising. So the carbon footprint for pharmaceuticals comes from many sources, like raw materials, manufacturing, transportation, incineration, which releases toxins into the air, and medications contaminating the water, and in our landfills. So we have this wonderful opportunity to help our patients avoid the harm of overprescribing, and at the same time, reduce the carbon footprint of the biggest source of greenhouse gases emissions in healthcare. So let's get to it and Over to you, Dee.
Thanks so much, Megan, and hi everybody in my two homes. I'm going to start with some terminology that is really helpful in describing and identifying clinical scenarios that we see every day where the system has created this low-hanging fruit for us to see and target in reducing unnecessary or perhaps low-value use of medications, really flagging out opportunities. Next slide. So the first term we're going to use today is the one called legacy drugs. Legacy drugs is medications that we prescribe where the evidence of benefit is for an intermediate length course, beyond, say, the short courses we might prescribe antibiotics for, but never were they intended to be a life sentence. So when continued beyond the indicated period, they become termed legacy drugs. And drugs that are included in this kind of length of prescription are PPIs, antidepressants, drugs like that. And often this happens not because we're poor prescribers, but because our system is well designed for starting drugs, but not well designed for flagging for us and for patients when we should be having conversations about stopping these intermediate course length medications. So we did a study to look at what the opportunity was here, using the McMaster practice-based research network in Hamilton to see what the extent of legacy prescribing was, i.e. what's our opportunity here. And we chose 3 classes of legacy drugs as indicators: one for physical symptoms, that's PPIs, one for psychological symptoms, that's SSRIs, and one for preventive care, bisphosphonates. And you can see here the usual recommended course length, that intermediate course length. We chose really conservative criteria to look for the extent of legacy prescribing well beyond these recommended course lengths. So for example, at PPIs and SSRIs, we only looked for prescriptions that went beyond 15 months in length. And you can see from the numbers in the dark green bar at the top, the proportion of patients that we start on a first prescription for these drugs, the proportion that go on into that legacy prescribing, i.e. beyond the length of time at which the evidence suggests they're beneficial to patients, is really quite high. You have nearly a 50% chance if you start on a PPI or an antidepressant that you're going to carry on into that legacy period. And the important thing about this is that it's not just a short duration of legacy prescribing. It's not a little bit of slippage, but the median duration was around about 5 years. So just the next slide. There will not be a person on this call who doesn't recognise this term prescribing cascade and doesn't recognise these very well-known prescribing cascade associations. But simply put, it's when a new drug is prescribed for an unrecognised side effect of an existing drug, rather than addressing that root cause of the original drug. And these are all common ones. We're going to talk later on some examples of less common ones to flag. So really, for every new symptom or condition such as hypertension, or for these common prescribing cascade symptoms such as dyspepsia, say insomnia, depression, that are really important to patients' quality of life, we know we should always ask this question, could the medications be causing this symptom? And being triggered by the kind of symptoms, just to think about this and to look back at the timing of any drug introductions and the start of those sort of symptoms is the key to really not missing this. And the last term I'm going to use is deprescribing, and this is the planned and supervised process of dose reduction or stopping of medication that may be causing harm or no longer providing the initial benefit when prescribing was started. It's a very gentle art. It is evidence-based. So in a study we did over a decade ago now, we looked at a cohort of older adults. We stopped every drug that wasn't life essential. We paused them, gave the patients a drug holiday, and then we restarted those that seemed still necessary. And what we found was that we could discontinue over half of the drugs in this older adult cohort, that 4 out of 5 didn't need to be restarted as we paused and monitored, and that a high proportion of patients reported feeling a lot better. So it's evidence-based and it's good for patients. It improves patients' quality of life. Polypharmacy is also associated with increased underuse of prescribed medications as well. So sometimes with polypharmacy in the patient with 15 drugs, it may be that they're so burdened by these drugs that we don't have space to provide a drug that actually may be of greater benefit than many of the drugs they're currently on. So clearing the decks of polypharmacy actually helps us focus on the drugs that are really important. But we know for sure that polypharmacy is associated with increased mortality in older adults as well as morbidity. And as you can see, this risk is not just from individual drugs. You can see here individual drugs that we all know well are associated with increased fall risk in older adults. You can see, aside from these very specific direct side effects, the risk from the number of medications is actually the highest risk. So just decreasing polypharmacy overall will have a huge benefit just from this really important side effect alone. So the last thing I'm going to talk about is the idea of low value care. And that's care, or in this case, what we're talking about today is medication that is of marginal benefit to the patient for the risks. So you can see clearly in this image from James McCormick of the Therapeutics Education Collaboration, the placebo effect shown here is a snake oil bottle. And then the value of the chemical effect of the drug over this placebo or snake oil effect is shown with the blue arrow. You can look at the detail of the slide later, but the thing to notice here, in examples like antibiotics for sinusitis, the effect of prescribing is almost all in the placebo. Any snake oil would do this. And the additional risks of the chemical for these drugs for individuals where there is little value added is usually not worth it in terms of both the individual patient risk and also the planetary risks. So figuring out how to convey this to patients is key. And we can see that a statement like, say, 2/3 of patients who take an antidepressant will have remission of their symptoms, or 85% of people who take an antibiotic for sinusitis will be better in a week, is not really making this clear. And using shared decision-making conversations and tools to help patients understand is clearly what the actual benefit of the chemical in the prescription is. The blue arrow, which is the absolute benefit, is really important because we know that both we and patients routinely overestimate the treatment benefits, that blue arrow. And we often don't use language that conveys the magnitude of that blue arrow in ways that patients can understand. But when we use shared decision making, we know that healthcare utilisation is reduced and the patient outcomes are better. And we'll show some examples in the next section for decisions, tools to support shared decision making around things like statins and bone density medications. So now getting on to the practical and the specific, we picked these very commonly used medications to show some examples of shared decision-making opportunities, legacy drug opportunities for reducing our carbon footprint. So we hope these will be practical tips you can take into everyday practice. We're going to look first at statins. So never was there a more ideal opportunity for shared decision-making and decisions about whether to treat risk to prevent future illness. So understanding how to communicate the blue arrow, we're going to share with you some of the highest quality tools available, or when I say we, I mean Megan is going to lead this.
Here is a shared decision-making tool I use for discussions of cholesterol and starting statin therapy for primary prevention with my patients. The cardiovascular risk calculator gives a personal absolute risk of a coronary event in the next 10 years. When my patients are part of the decision-making and have the absolute risk reduction numbers for statins versus other non-pharmacological behavioral changes, we understand the benefits of each, which often surprises both of us. It is embedded into my EMR, so it pulls in the age and the gender, the blood pressure, and the cholesterol, and I can input the smoking status and the diabetes. And in this case of the 64-year-old male smoker, you can see that his risk of a cardiac event is 30%. It's a good picture. He can understand it when he sees the smiling and the unhappy and the unhappy faces. So working through his options, he can then see that if he gets regular physical activity, it lowers his risk to 23%. If he eats a diet rich in plants, it lowers his risk to 21%. Starting a statin therapy lowers his risk to 23%, which is not as much of reduction as the dietary changes. And then it also goes over the risks of the statin therapy. And then he can also see what happens when he quits smoking, which lowers his risk to 17%. The tool creates documentation that can then be saved in your EMR automatically. And we work in nurse physician teams, and we both use this tool.
So what are the risks to consider then to balance against this potential benefit? So statins are associated with side effects that are really important to patient quality of life. And they're actually, as you can see from this slide, they're really easy for us us and the patient to misattribute to something else. The risks are increased if you're a woman and if you're over 80 and if you've got other comorbidities and frailty. So the very group who are at higher risk of adverse events and least able to cope with those. You'll notice on the tool that Megan just showed you, there's a dose button. So dose really matters. The higher the dose of statins, the higher the risk of side effects. And with statins, there is a really diminishing return with higher doses as well. So the biggest bang for your buck in terms of the percentage benefit is with the lowest dose. And then the incremental additional benefit is much smaller as you increase. The dose response curve really flattens out very quickly. So we know that minimizing the dose also reduces both the footprint and the side effects for the individual patient. Statins also have multiple drug interactions, and this is another reason to prescribe judiciously, both in terms of the decision to prescribe and also the doses. Almost all patients on statins, as we know, are on multiple drugs. And here's some examples of potential interactions, and they vary across different statins, but some occur across all and can be very significant. For example, diltiazem and statins, it can be vary from patient to patient, but diltiazem can increase the concentration of a statin by up to 6 times, which, that you can see easily the effect that might have on side effects. And so, as I said, dose matters. And as with almost any side effect, a lot of the time it's simply a matter of adjusting down the statin's dose. But if our patients are not on a heroic dose of statins to start with, then their risk is automatically reduced. And there's an excellent resource that we've put in here from the American Heart Association for managing these interactions, which we'll also post in the chat. So moving now to bisphosphonates, again, one of the legacy prescriptions that we see commonly in a high proportion of our patients. In our study, for example, we found that 60% of people with legacy prescriptions were currently taking them. So there's a huge opportunity here in these legacy drugs. A study spanning nearly 10 years showed that of seniors eligible for benefit coverage, we could see the data in Canada, those with the prescription of bisphosphonates increased from 11 to 20% of women over a 10-year period. So the uses really increase. And we found that 1 in 10 patients received these for beyond the period of evidence for impact. And also that we found that many people stop these drugs themselves, indicating both ambivalence about taking them and also perhaps side effects. So therefore, a great opportunity again here for shared decision-making tools like this next one.
Here's another decision aid. It's currently not in my electronic medical records, so I Google Mayo Bone Health. It enables shared decision-making around osteoporosis and osteopenia. I input the patient's age and their gender, their ethnicity, bone density, if they have any other risks, and it calculates their absolute risk over the next 10 years of having a fracture with this nice picture that's easy for patients to look at and understand too. I can then show them what an intervention would look like of giving them, for example, a bisphosphonate, which their 10-year fracture will be reduced from 9 to 5 with that intervention. The decision aid also shows us some of the side effects in detail of the bone density medication. And it has some suggestions for non-pharmacological ways of reducing fracture risk. And to document the visit from my patient, I can easily cut and paste this into my electronic medical record.
So our job with these, with treatment of risk factors, is not to persuade people to take the medications, but to help them to decide whether they would like to or not. And like statins, bisphosphonates have side effects that need to be traded off against the potential benefits. And again, they're both easily missed by both us and patients and really affect quality of life, as you can see here. Dentists often report anecdotally that they can tell whether which patients are on bisphosphonates when they do dental work. And some of these side effects are rare, but when they happen, they are really devastating. And so we want to be sure that we and the patient feel that the benefit is worth it to that particular patient and that they're not being prescribed beyond the evidence for benefit. Because being haunted by prescribing regret when in retrospect a medication was low value or legacy is awful for both us and for patients when one of these devastating side effects happen. So when and why to consider discontinuing? Well, bisphosphonates have this really lovely effect. They have an ongoing benefit after being stopped. The drug remains in the bone and is released into the body. We know that even in the longest follow-up that has been after stopping bisphosphonates, after around 5 years of use, the bone mineral density doesn't actually return to the level it was at when we started them. And there are recommendations that you can see here that are based on this effect, and that also take into account the patients with a very low initial bone mineral density that we might want to continue, so a T-score of less than 2.5, say, or who have a very high fracture risk where there may be some benefit from that extended treatment. I'm not going to dwell on this. You can go back and look at this yourself. But the things to think about when starting a drug for bone mineral density, what type of drug to start, is really important because it has implications for our future ability to stop. So looking at the two common classes of treatments for preventing osteoporosis, you can see here from the dark green block that there is no difference between the effectiveness when on treatment of these two classes. But on stopping, there are big differences. So bisphosphonates have this legacy benefit that I was speaking of on bone density, and that plays out in continuing to prevent clinically important fractures in the follow-up of 5 years or more, as you can see after stopping, after 3 to 5 years initial use. And I would normally use initially for 5 years. Whereas on stopping Prolia, denosumab, users experience an immediate and significant loss of bone density, losing really all the gains we've made within 2 years, with most of the bone loss happening in the first 12 months after the last injection. So there's also a big difference in costs, as you can see, which is important to both patients and strained health systems. So now moving on to some practical tips around SSRIs and deprescribing. So as we know, there is an ongoing growth in the prescription of antidepressants. And this growth is not because we're recognizing more depression and starting people, it's because more people are going on them and staying on them. So they're moving into that legacy prescribing phase. And in fact, SSRIs are Canada's seventh most prescribed drug class by program spending. And this graph is exactly the same if we look at the New Zealand data, that increase over time. And as I said, most of it is not from starting more, it's from not stopping. And so you can see in these two pieces of data here that the legacy prescribing, the mean duration if we start a prescription for an SSRI is not just a small bit of slippage, as I said, it's nearly 5 years if you start that you're still on the SSRI. So this is well beyond the recommended duration, even for a sort of a more longer term use, which is usually recommended for 2 to 3 years. So a huge opportunity here. And other studies in the UK have shown when they looked at individual patients that, between a third and a half of patients have no evidence-based indication at all to be continuing treatment. Now, the other important thing about antidepressants is they're also part of a prescribing code, which we recognise less often. So there was a lovely study done a few years ago, just before COVID, that showed that in the US, a third of adults were taking a drug that can cause depression as a side effect. So this includes drugs that we prescribe very commonly, like beta blockers, PPIs, H2 blockers, ACE inhibitors, anxiolytics, ibuprofen, oxycodone, anticonvulsants. So a lot of the drugs that we prescribe commonly. An easy one to miss. It's an easy one to miss that this is a drug side effect. And you can see here in the next slide, there's a dose response effect. So the more medications you're on that can cause depression as a side effect, the more likely you are to receive a subsequent diagnosis and prescription for depression. So the effect is real and at an important level, reaching 15% of patients on 3 or more of these kinds of medications. And these are both common. Depression is also a risk from polypharmacy in general. And we know polypharmacy is associated with symptoms that can mimic depression like these. And these are so common in our older adult population, are very easy to misattribute unless we and our patients are alert to this. But the tricky thing is that neither we nor the patients want the horrible experience of depression to return. And so, you know, one of the drivers for continuing the prescription is to think, well, things are good now, why rock the boat? And so there are several reasons for rocking the boat when the waters are calm. The first is that the guidelines for ongoing treatment are pretty loose for us in primary care. So you can see here the current guidelines for maintenance treatment. And you can see there, I mean, if we look at ourselves over the last few years, I don't think there would be anybody in this room who wouldn't put up their hand and say they've had ongoing psychosocial stressors of some kind. So you can see it's very easy to justify ongoing prescription, but there's not really solid evidence for this. These are opinion-based. And the other thing to remember is that the natural history of depression is not like diabetes. It doesn't return immediately you stop the drugs. It's episodic. So the medications, SSRIs, don't cure the depression. How they work is they help to alleviate the symptoms of the depression while the episode is present until it remits. And we know that usually that's around 6 months, which is why our usual recommended course is around 6 months after we start to see that effect. An episode of depression also typically remits naturally with or without the medications. But too often patients then stay on the SSRIs after the depression episode will have settled. And we and the patients all think they're well. We assume they're well because they're still on the medications, when in fact it's because that episode has resolved. So again, if we think back to that low value care slide, the chemical benefit of antidepressants is quite small over placebo, as we know. And it becomes even smaller when we apply this kind of evidence from trials of SSRIs and depressions to our primary care patients. For these reasons, our patients are different usually to the patients that have been in depression trials. And I'm not going to read these individually, but as you will all be very well aware, these kinds of things all overestimate effect, these biases in trials. So we can say that the benefits are modest at best, and there are other treatments available. There's very little evidence for efficacy specifically in older adults, but what we do have is not an absence of evidence in dementia, but we do have evidence that in patients with dementia, there's evidence that there is no benefit of antidepressants. And that's an important group because we often will, until the diagnosis is clear of dementia, we'll often start an antidepressant in case the symptoms are depression. And sometimes we forget to stop it when the alternate diagnosis is made. To touch on a few things that are really important to patients on the list of side effects that balance that effect. So at best, we see, you know, a sort of 15% effect in the acute episode, and I'll go over the benefit in the long-term treatment in a minute. But to balance against that benefit, these are the significant harms of long-term SSRI prescription. And I think just to touch on a couple, the bleeding risk is actually at a significant level. The bleeding risk with SSRIs is the same degree to that one that we're much more alert to, which is the bleeding risk in older adults with anti-inflammatories. And this is all kinds of bleeding because the effect is on the serotonin and platelets. The falls risk, we know about tricyclics and the fall risk. We're really well aware of this, but actually the risk with SSRIs is the same as the risk with TCAs of falls. And sleep disturbance is something that's really, we know, a big concern to our older adults. And SSRIs affect both the total sleep time, awakenings, and sleep latency, so trouble getting off to sleep. So important benefit harms for patient quality of life. So there are now a couple of trials for testing the long-term benefit of antidepressants used for maintenance in the primary care population. And at conflict of interest, I was involved in both of them. But we found in these trials that the results were very similar. We found that 7 out of 8 of those taking antidepressants in the primary care setting experienced no benefit, i.e. it doesn't prevent an episode of depression over an 18-month period. So only 12.8% of patients benefit in the trial. So the number needed to treat for 18 months is 8. So it's a really useful piece of data when discussing, you know, whether to carry on or stop with patients. But importantly, what we found was that even with a very slow taper of fluoxetine, which is easier to taper, 1 in 16 of those taking antidepressants was unable to discontinue because of the withdrawal severity. So that's really important thing to think about when you're starting someone on an antidepressant as well. So the number needed to harm was 16 for that. In these studies also, there's the important question for patients, you know, is there any harm in trying to pause to have a drug holiday? And what we found in following these patients who had a trial of discontinuation with taper, that there was no suggestion of poorer outcomes for those in the arm where discontinuation was trialled, and that around about 50% of them could discontinue very successfully without either a return of depression, without intolerable withdrawal, and with no sort of patient desire to go back on them for some of their other effects as well. So that number needed to trial to stop 1 is 2, which is pretty good bang for your buck in terms of a sort of clinical intervention and reducing the risks for patients. So how to stop? For both SSRIs and SNRIs, consider the length of time that the person's been taking the antidepressant. As with any drugs, I think, the older I get, the slower I go with stopping things that people have been on for, a decade or 2. There's no rush. They've been on them for a long time, and let's gently let the body adjust to being without the chemical. So as a rule of thumb, if they've been on them for months, take them at least weeks to stop. If they've been on them for years, then plan on taking months to stop. And that helps the patient to engage with the idea too, if they have a sense that this is going to be a gentle process, because many of them have had withdrawal symptoms if they've missed a tablet, and they're very unpleasant. Some kinds of drugs have more significant discontinuation problems, for example, paroxetine and venlafaxine. And so an important consideration when choosing which drug to start, because they all have equal efficacy. The difference is just in the side effect profiles. And we also letting patients know what to expect when they stop. These symptoms, which we're all familiar with, of withdrawal symptom, it's really important to warn patients, to let them know, to let us know, because it might mean we're going a bit fast, and to reassure them that although they're really unpleasant, they're not harmful. Listening to their experience of withdrawal is really important, I think, and I think allowing them to control the rate of stopping to what's tolerable for them is really essential in being successful. And there's some practical tips for approaching stopping. Apart from letting the patients control the rate, try a small step to start to see how they're going to go. So maybe try 10% reduction and then 25% if they've had no issue with the 10%. And just this graph on the right is to visually show that the taper is not a linear thing for SSRIs. It may need to be a lot slower towards the end, because the withdrawal symptoms seem to relate not to the drug level, which drops off in a linear way, but to the serotonin receptor occupancy, which you can see if you go from the right to the left, that represents the citalopram dose. You can see the drop off in serotonin receptor occupancy really crashes as you get to smaller doses. So at the very end of the taper, we may need to go in very tiny doses, and you can see in the bottom table just how tiny those doses may need to be. The only other thing I would say, sometimes it's suggested that we alternate days, and that can be very unhelpful for patients, especially with the shorter half-life drugs, because they get withdrawal, not withdrawal, withdrawal, not withdrawal. So I wouldn't recommend that, except sometimes with fluoxetine. So the key points from the primary care trials: we overestimate the magnitude of benefits for our patients. Most of the benefit is from the placebo. Most people are not benefiting from long-term maintenance treatment, and it's reasonable to suggest a trial of medication discontinuation to all patients, a pause and monitor. Most will be able to discontinue. Some people may not be able to stop, but that people will come to no harm from trialing stopping, and that shared decision-making and a gentle approach is the best. So just moving now to PPIs, and the rate of prescription is high in both New Zealand and in Canada. They're the second most used class in Canada, and it's used because they're actually very effective in terms of controlling acute GI symptoms. As we all know, the number needed to treat is very low, so they're high value in this initial situation of controlling symptoms. But there's some clear recommendations on ongoing use of PPIs. They're never intended to be a life sentence. They're intended to control the symptoms and then try and back titrate to the lowest minimum dose or PRN, or to stop once you've got other measures in place. So here's just some examples of some recommendations around ongoing use of PPIs. And when we looked at the opportunity here of the legacy prescribing, again, we found very similar to SSRIs, that nearly half have no indication for ongoing use. And in our study, we found that if you started on a PPI, you're more than likely to carry on for a period of at least 5 years. And there's important both direct and indirect side effects of PPIs to discuss with patients. There are direct ones, which are usually obvious to the patient, things like GI side effects, effect on absorption of important vitamins and minerals, but other things that take longer and are less obvious: hip fracture, increased risk of pneumonia, and then indirect side effects because they contribute to these other harmful effects of polypharmacy in general. So how to stop? In studies, the discontinuations range from about 14 to 86% without deteriorating symptom control. Tapering seems to be a more effective cessation method, but there's not clear evidence around that. And there's no evidence here of any particular pattern of tapering that's better. So using shared decision-making and let the patient control is the best approach. And these are the kinds of successful approaches, I think, for reducing PPIs, because they are hard to reduce because of that rebound that you get of acidity, which is really important to warn patients about. It doesn't mean that they still need the drug, it's just their body settling into being without that acid suppression. So dose reduction is helpful in reducing harms and in tapering to nothing. They can stop, or what I found really effective is shifting to PRN dosing. So that lets the patient take control. And I find over time, if you switch to PRN, the patient tends to use them less and less. There are a couple of toolkits here, which you can scan off the slides later using these QRS codes, and there's also a link posted in the chat. So just hopping back to you, Megan, for the next piece.
Okay, great. I'm going to quickly go over meter dose inhalers. We do have a 25-minute recording of a webinar on this topic on our website. So this is just a sample. In the webinar, we review how we can improve patients' respiratory health with accurately diagnosing COPD and asthma using spirometry, treating with evidence-based guidelines, and then ensuring proper technique. So that is all improves our patients' health. And then there's a corresponding large reduction in greenhouse gas emissions because 1 meter dose inhaler is equivalent to a 290-kilometer journey due to the propellant. And in Canada, there's over 900,000 salbutamol inhalers, so just one example of a meter dose inhaler, distributed every month, which is astounding and disturbing. And explains this bar chart of UK emissions. So this is the primary care emissions. And you can see that pharmaceuticals, and then specifically meter dose inhalers and aesthetic gases, are a significant source of greenhouse gases. This was our first topic within the Green Initiative. And so besides the webinar recording, we created quite a few tools, an evidence-based reference guide, a summary of different kinds of puffers, in the relative carbon footprint, a poster to put up in your office, and they are all on our website for you to use. So back to you, Dee, to discuss the barriers to prescribing for impact.
Yep. So it's really important not just to think about what's going to be our approach to drugs, but how we're going to approach these conversations. And what we see here are some of the things we know that can act as barriers to deprescribing. And these are really important to consider as you think about how to introduce to your practice. For us and patients, though, these are fears rather than actual risks. And patients want to reduce their medications, but they wonder if we will support them in this process. So that's important to be clear about. This is a pause and monitor, not just stopping the drugs. They worry if they'll be able to restart if they find they were of benefit. So it's important to be clear about that you will consider restarting and agree on your criteria for restarting, and understanding what to expect in the withdrawal process, and having a way of explaining why medications that were very useful for a period or when they're initiated are no longer useful, either because they're legacy drugs or because the evidence from somebody started on, say, a beta blocker or a statin 30 years ago, the evidence of what we know about them has shifted. And for us, really, there's compelling, I hope you feel like at the end of the session, there are compelling reasons to do this, to take on this work. We really can't afford not to, both for individual patients' benefit, but also for planetary health. And for us, addressing our own fears and concerns is really important in thinking about how to take a bite-sized piece to start in our day-to-day practice. We don't have to take it all on all at once. And the best thing to do is just choose a bite-sized piece to take on. And hopefully with some of the support tools that they've given you that will provide a sort of solid foundation and some guidance. Thinking about a few other tips and strategies that you might find helpful in this. So what you have all just illustrated is that, and it's important to communicate to patients, is that reducing medication use doesn't mean that we're not supporting our patient with treatment. And these alternatives to medication are well known to all of you, and frequently they have very potent effect sizes, often higher, as good as or better than the chemical benefit of the medications. And you'll notice on the cardiovascular risk tool, you can show the patients the relative benefits of the lifestyle approaches and the drugs, and that's often very powerful. Being able to reduce their medication burden is a great motivator for patients to engage with these. And so as you're discussing reducing, say, cardiovascular drugs, at the same time you can say, okay, let's see how low we can get them if you can engage with these other things. So it's a powerful motivator as well. These strategies require the same follow-up and monitoring as medication, supporting patients with adherence, monitoring for effects, as well as whether medications might need to be reintroduced at some future time point. And this really helps with some of those patient unspoken barriers, that discontinuation is not abandonment, but they support discontinuation as part of an active management strategy. And this is an ongoing conversation because they're worth it. And you'll see, if you scan this QR code, a number of resources from the Hamilton Family Health Team to support these non-pharmacological treatments. Moving to some more specific strategies and supports that will help make discontinuation more seamless. Discussing the decisions and when you decide to start prescribing, or when a drug has been started in hospital and you see it on discharge, the reasons for starting and the anticipated course length. I say, typically a course of antidepressants is this long, and that's critical, and also flagging when you'll taper, that's part of the plan. So I usually say typically it's this long, and next spring we'll have a conversation about then tapering you off, because you'll have had the benefit of that course. So flagging at the outset is really important, and it makes the conversation at the time of tapering much easier. Finding these points like discharge from hospital, it can trigger the sort of planning for review and a sort of a relook at those kinds of legacy drugs, because we find often the legacy drugs are started during hospital admissions and were never intended to carry on. Managing expectations, the way you put it, can be helpful. So you can say, most people need this medication for X months or years, and we will review it as usual at this time. And put in a flag in your electronic record, your PHR in New Zealand and your EMR in Canada, for that end of the course length, or make a start note date in your EMR so that you can all remember. You'll all develop your own narratives around that, but that's just kind of an example. Another strategy is to just pick one medication to pay attention to reduce the prescribing across your practice when you're renewing it. Flag a chart of patients that need discussion, or write in the prescription, and only give 30 or 100 days of the prescription before you need to bring them back in to review. And describing should be a really gentle art. And generally I find with a long-term medications are old friends to patients, and it's good to just introduce the idea in a way that gives the patient time to think about it. So in a consultation, I might say, oh, look, we probably need to look at your antidepressant. You've been on it a long time, and I'm not sure that you're still benefiting. So next time you come in, let's have a discussion about whether we can reduce that a bit, so that it's not sudden or abrupt or unexpected. Taking a symptom approach is another way. So every patient who has falls or confusion or insomnia, you could look at, is there an opportunity for deprescribing here? Or you can bring in, and this is what I'd love to see in our everyday practice in primary care, and looking at our annual prescribing cycles, to think about annual deprescribing as well. So reviewing every patient with polypharmacy to see are there opportunities to reduce, and trying to write all your prescriptions so that they all line up for their renewal date, so that you have an opportunity to see all at once and make sense of it all together. So these are some strategies for supporting patients, and it's important for patients to feel supported and reassured, as I keep reiterating, about the common concerns about deprescribing and about monitoring. And you'll all develop your own approaches, but these are some approaches that I found helpful. And it's really important also for patients and us not to feel that if we have to restart the medication, that it's a failure. It's not. That's really effective monitoring. So every drug deserves a holiday, and most patients are open to the idea of a drug holiday or a trial of reduction. And I often use this phrase, pause and monitor, because it's something that patients can really relate to. This gives the patients a sense of safety and control, and opens the conversation for them to feel free to tell us how they're experiencing these effects of deprescribing. Engaging the whole team is really important, and we have team-based care in both Canada and New Zealand, which is amazing. So if you have access to a practice-based pharmacist or a good relationship with your community pharmacist, refer patients over age 65 on multiple meds, so it can be the whole team looking at this. Pharmacists are really technical medication experts, and we need to sort of use the skill as a part of our team approach. And then tapering, there's a few tips here. So, you know, as you'll all have thought when I was talking about SSRIs, but the tablets don't come in that size. So there are some practical tips we can use to try and get that slow taper. So you can tablet split, which you're all pretty familiar with. You can use liquid preparations when they're available, but often they're not, especially for the SSRIs. And you can use a compounding pharmacy, but that can be expensive for patients. But for example, again, this is where we engage with our key colleagues if we're prescribed as pharmacists. For example, most tablet form non-extended release SSRIs can be dissolved in water, and a proportion of the resultant well-shaken liquid can be calculated and drawn up in a syringe. That's not stable, so you have to discard the rest, but that can be a way of getting a much smaller proportion of the dose, and getting the pharmacist to help supervise the patients with this kind of approach is, I find, really helpful. Here's our lovely team, and I'm just going to hand back to you, Megan, for this last piece.
Thank you. So before we move on, this is one non-pharmaceutical support that we've created that's open to all patients across Canada by self-referral on how to eat plant-rich. So if you're interested in this topic, we do have a webinar recording on it, similar to the one today, with evidence-based benefits. And you're welcome to print this poster from our website and put it up in your exam room so your patients can attend the 2 90-minute sessions led by a registered dietitian. Thank you, everybody, for joining us.